The learning objectives for the two cases that I have with regard to aortic disease are to review the cases of aortic dilatation and the approach that I use in my practice to make a diagnosis, to discuss patterns of aortopathy related to specific disorders, and to explore suggested timing of intervention. So the first case is a 48-year-old man. I saw him just within the last month. He had a murmur noted on physical exam and was referred for an echocardiogram, and then that prompted his evaluation and referral to us. No known prior cardiovascular disease and symptoms, and you can see his physical exam, height 190 centimeters, normal blood pressure and heart rate, normal saturation, BMI, pretty normal for the Midwest. And his exam otherwise was normal or remarkable for an ejection click and a systolic murmur. He had no syndromic features. Electrocardiogram and chest X-ray. And let's look at his echocardiogram. So focus on the aorta. Of course, this is the aortic session, so it wouldn't be surprising that there's an abnormality there. You don't even have to have had coffee in the break in order to. So here we are. The aortic root is 50 millimeters, sinotubular junction 42 millimeters, proximal ascending aorta 47 millimeters, and then additional adjustment probe demonstrates a mid-ascending aorta of 49 millimeters. And then apical long axis here, you can see the aortic valve mean gradient is 13. Normal ventricular function. No, I'm not hiding anything from you, no low output or anything like that. And then you can see there's just trivial aortic valve regurgitation. And then descending aorta was difficult to visualize from the suprasternal notch, but here's his abdominal aortic pulse wave Doppler. So, what would you suggest? Observation and follow-up in a year, surgical intervention, CT or MRI, genetic consultation and testing, or something else? So I think very importantly, most of you have answered CT or MR, and I think that would be a very appropriate thing to do. Not that some of the other things would not be unreasonable, and we'll talk about that in a little bit more detail. So when we approach patients with a dilated aorta, the differential diagnosis that comes to mind is demonstrated here on this pie diagram. Of course, specific features will help us differentiate some of these differentials. If the patient is in their 70s or 80s, I think we all would think more likely of a sporadic disorder. If they're like this patient in his 40s, we think about some of the other differentials as demonstrated here. Inflammatory giant cell is the most common thing that we see, and this patient's a little young for that. I told you he had no syndromic features, and I'm not trying to hide anything. This would be an important thing to ask about, and then of course, the echocardiogram might have helped us with this particular diagnosis. Bicuspid valve-related aortopathy is a very common entity, and we'll talk about that some more. But I think it's really important to emphasize that the presence of a bicuspid aortic valve doesn't exclude a different diagnosis, and we have to keep that in mind when we see these patients and not just close the door too early and say that's the diagnosis. And so we go through this comprehensive approach, take a full history and a comprehensive family history, do a thorough physical exam, and then imaging. And here I think most of you wanted to do additional imaging, and I think that's very important in this patient population. Cross-sectional imaging with CT or MR is very helpful in further assessment of these patients. And then we have now a very low threshold to do genetic consultation, and many of these patients will have genetic testing as well. And that is very, I think, helpful in many of these patients and some additional patients that you'll see presented here. With all of that information, we try to come up with a diagnosis. What does this patient have? And then how are we going to follow the patient? What is the threshold for intervention? And so on. And so just as you requested, we did a CT scan, and I just picked some representative images from that. And it again demonstrated dilatation of the aortic root, somewhat more than the mid-ascending aorta. Importantly, there was no evidence of coarctation, and no other aneurysms were identified in this patient. So now what are you going to do? Genetic consultation and testing. Nandan, would you agree? Yeah, anything else, Soren, Buzz?
You already did the cross-sectional imaging. The one thing I was going to say is I started measuring the 3D dimension of the sinus, especially that's accessible, and to a lesser degree the mid-ascending. It's surprising how often we underestimate from the standard parasternal the dimension of the sinus.
I think that's a great comment, and I'm going to come back to some of the imaging tips in this patient population. Did you have another comment, Buzz?
Well, just with the sinuses 50 on the CT?
50, yeah, 50, yeah, on the CT as well.
So I'm just thinking observation, but since it's the first time it's been diagnosed, I might do the observation earlier, like, 6 months, something like that.
Yeah, and so we offered genetic consultation and testing. The patient was not interested at this time, but that would be very appropriate. And particularly, I have a low threshold for doing that in this patient population if the sinus dimension is the largest dimension. So what does this patient have? Anybody want to shout it out? I think additional information is helpful, so here's some additional family history. No aortic aneurysm, brain aneurysm, dissection, or sudden death history, and no known bicuspid aortic valve. So this patient has bicuspid valve-related aortopathy. You saw the bicuspid valve on the echocardiogram. And remember that although the most common fate of the bicuspid valve is aortic stenosis, up to 50% of patients with bicuspid valves will develop or eventually have aortic dilatation. So this is a very important topic. The pathophysiology of it is not completely sorted out. Lots of different suggested entities: genetics, epigenetics, environmental, altered signaling, and hemodynamics. But in patients who have bicuspid aortic valve without any other features, with mid-ascending aortic dilatation, genetic testing is not very helpful in those individuals. If the root is dilated, I think you have to have a higher index of suspicion that there may be a different etiology. So just a couple of examples here. These are different patients. Obviously, nice bicuspid aortic valve with right and left cusp fusion. I think Soren nicely emphasized that you need to look at this both in the long axis but also in the short axis view to get a measurement. But note that in this patient, although the root is dilated, it's the mid-ascending aorta that's most markedly enlarged. So imaging tip, again, for those of you who image, and particularly for the sonographers, in individuals with bicuspid aortic valve, look not just at the valve and the root, but look at the mid-ascending aorta. That's the most common site of aortic dilatation. And then also look both at short and long axis. This is a different patient, also has a bicuspid aortic valve with right and left cusp fusion. And you can see also asymmetric dilatation, and this short axis demonstrates that the longest axis of the root would be here in this particular arrangement. In fact, this patient had a bicuspid aortic valve and a dilated aortic root, but he also met criteria for Marfan syndrome. So again, just to re-emphasize that the presence of a bicuspid valve doesn't mandate that that's the diagnosis. So really important to remember that. And here again, the imaging tip for the sonographers is to measure the sinuses, not just in that long axis view that we standardly and routinely use, but also look at it in the short axis view, similar to what we see with cross-sectional imaging, and I'll show that in another case shortly. I think one of the big questions that always comes up is, when do we intervene on these patients? And so for patients who have bicuspid valve-related aortopathy, the standard of care is to intervene on the aorta if there's no associated valve disease when it is greater than 5.5 centimeters or 55 millimeters. However, in select patients, we would decrease the intervention for those individuals who have high-risk features, and that includes a personal history or family history of aortic dissection, rapid enlargement of the aorta, or planned pregnancy. In addition, if patients have aortic valve disease that requires intervention, then those patients who have an enlarged aorta, if it meets criteria of about 4.5 centimeters or more, should have that intervened on at the time of operative intervention, or that's at least what our guidelines suggest. So in general, we would observe the patient that is presented, and I'll go through how I manage that patient. I think one caveat to these recommendations is that one should be very cautious about, again, the bicuspid valve patient, and remember that there are other associated conditions that can occur, particularly Turner syndrome. Obviously, our patient was a male, and he doesn't have Turner syndrome, but one should be on the lookout for that patient population. If a patient has Turner syndrome and a dilated aorta, the threshold for intervention depends on an indexed dimension. So it's indexed to body surface area, and that's demonstrated there. So greater than 2.5 centimeters per meter squared in general, but there are also high-risk features that might change that timing and extent of intervention. So just a couple things about bicuspid valve-related aortopathy. Again, I've already emphasized that it's common, and there is a chance that it can be associated with aortic dissection, as demonstrated in an Olmsted County study done by one of our colleagues, Hector Michelina. And so although the chance of aortic dissection is small, it does occur in patients with bicuspid aortic valve. And so lifelong follow-up is required. And I think that's, again, highlighted by this patient. 47-year-old man, lives in Olmsted County where we work, had operative intervention at age 7 for a bicuspid aortic, and never had a follow-up echo until this echocardiogram. And you can see he had not just a giant ascending aorta, but also chronic aortic dissection. So really emphasizing the need for lifelong follow-up in this patient population. We don't know any medications that are effective in patients with bicuspid aortic valve and aortopathy. That is, that we don't know that medications decrease the rate at which the aorta enlarges, but we do know that some medications should be avoided if possible. The FDA put out a warning in December 2018 that the fluoroquinolone antibiotics increase the likelihood of dissection and rupture in both population studies and a mouse model of Marfan syndrome. And therefore, it was recommended that these antibiotics be avoided by individuals who are at risk for aortic dissection unless benefit outweighs that potential risk. So I advise my patients to avoid these antibiotics whenever possible. I think family screening is something that's a little controversial. I do recommend family screening in my patients who have bicuspid aortic valve and aortopathy, and I emphasize that some of the first-degree family members can inherit the trait for a dilated aorta without having the bicuspid valve. You can see that this was also reviewed in the valvular heart disease guidelines, the most updated iteration, and this is in your handout for reference. And so some recommendations pretty much as outlined. So comprehensive care plan for this patient population. Lifestyle, important that their blood pressure is adequately controlled, that they avoid heavy isometric exercise, particularly if the aorta is large, as it was in our patient. They should be aware of the fact that they have an aneurysm, and if they develop chest discomfort, they should promptly go to an emergency department and let them know that they have this disorder And then as you recommended, and some I think we've talked about, genetic evaluation and testing should be considered, I think, in this patient population. So what I've recommended for him is evaluation again in 6 months. Since there was good correlation between the echo and the CT scan, I'll do an echo at that time. If his aorta is stable in 6 months, then I would see him back in a year. And then again, the threshold for intervention in him would be 55 millimeters unless we see a significant change or there's a change in the family history. In this patient, I don't think we need to do comprehensive surveillance of the rest of the vascular tree, but in individualized patient, so if it's a different diagnosis, obviously that will be very important. So again, the learning objectives for this case were to review a case of aortic dilatation and our approach in our aortic clinic to the evaluation and diagnosis in a particular patient, to review the patterns of bicuspid valve-related aortopathy, and then to explore timing of intervention for different diagnoses.